Thank you very much, Robyn. And I think this is a really appropriate way to close that scientific portion of the day, because it takes us into the possibilities of data mining, real-time data acquisition, really pushing the frontiers of use of data, the fact that routinely collected data, and that's broadly defined, can be used to identify epidemic outbreaks and who knows what else. That's a challenge for us because, as you know, there's a delay in data acquisition for many of the data sets. And most of the time in ISA studies, it doesn't matter very much, but it probably stops us moving into areas that we could provide an entirely new form of information for the province. And the hope is that working with a number of organisations, including Public Health Ontario, particularly identify that we will be able to do that. So thank you very much indeed for that, Robyn. Now we've got a bit of time, so I'm going to ask for people who've been a little reluctant this afternoon to step up and make comments or questions relating to Robyn's.
You have to remind them that they're the focus group.
So, Robyn, at one point you used the word end user. I thought that's interesting. How far down the line does that end user notion go? Because in the UK, I know they're beginning to incorporate patient views into research. In fact, incorporate patients in design of programs. So I'm curious to know what this opportunity is.
Yeah, I just came back from the UK, and in fact, I'm so fascinated. They're now coining the term citizen scientist, which I thought was really fascinating. I don't think we've gone far enough in that direction. The community-based primary healthcare innovation teams had to include end users, meaning patients and families, in the team. I think that's just one step, but I don't think we formalized the role. I don't think that we have engaged citizens in the way we should, in terms of the research enterprise, setting priorities and for the things that we need to get done, both at the healthcare end and at the research end. So I look forward to ideas about how we could do that. It was interesting to see what they had put in place and gave me certainly lots of ideas of what we could do here.
Michael. Robyn, I wanted to comment on two potential obstacles to sort of the progress you described over the next decade that I don't think you mentioned. One is the whole privacy agenda, so to speak, and how you see that evolving over the next decade. And the other, when you talk about big data and the opportunities, if I understand correctly, for more interjurisdictional comparisons, we've seen in Canada at least a lot of reluctance among jurisdictions to compare performance and outcomes between jurisdictions. How do you see that evolving as well over the next few years?
Just to comment on the privacy issues. Yeah, we do excel in terms of privacy and our preoccupations with that, and yet I think that we have put in place, both ISIS and the Manitoba Centre have put in place what I'd say is outstanding best practices approaches for managing data in a secure way. We have put together a request for the Canadian Council of Academies to address the issue for Canada. This is not the only solution, but I think it has to be part of it, to really have an independent report of what the risks and benefits really are. There seems to be, in consulting with the various groups across the country, there seems to be essentially a commonality internationally about where the barrier is. And the barrier is typically at the level, not at the most senior policy level, but at the data custodian level. And the data custodian, essentially, their number is up, in fact, if the data gets breached in some way. But if there's a lost benefit, that's completely invisible to them. So how do you actually balance the playing field in that regard? Do we need a commissioner of public good? Do we need, but we do need some sort of counterbalancing valence. One thing that I've thought that will be important is that we do not provide a means, and I think this is back to the real-time monitoring, of seeing the immediate benefit of having these data available. to people, both in terms of monitoring health system performance, making decisions about the care that's delivered. If we provided much more tangible benefits straight out to the consumer, which we could, let's say, with the Drug Safety and Effectiveness Network, that could be an example of getting back out in a complicated way, back to people to say your data is working for you. You know, this is a benefit to you. But we've not made that effort yet to get back out to the consumer who ultimately's data is being used to say, well, or at least maybe not to the extent that we could. So I think that's a big issue. I don't understand actually in our country, we have, for the Drug Safety and Effectiveness Network, we purchase data for the United Kingdom.
Right.
Like, get that. They're selling their data all over the place. It's just kind of, like, why is it they're doing that? We all sort of came from the sort of same, you know, it's not that their culture is so different than ours. So there's something about this that I don't really quite get as to why we're in that vote. But I do think that we actually have to show this benefit back immediately to the public in order to get the kind of traction at an individual level that your data is working for you, which I think it could through the Drug Safety and Effectiveness Network. So challenge over to them. In terms of the interjurisdictional comparisons, you know, I think if you set it up that there's a right and there's a wrong, I think you're getting into big trouble. But if you set it up in a network to say, you know, we don't really know whether this route or that route is the best way to go, is that to set it up a priori, prospectively, in a systematic way that we want to know, you're going to go down that road and I'm going to go down this road, and we actually are going to engage in trying to figure out which is the better way to do it. Because these are complex, typical, whenever there's a reform like this, or there is going to be a reform, is complex, multifaceted interventions of which you're going to take some pieces and you're going to look at some pieces, and some pieces will work better than others. So I think if we put it in a more learning environment, as a prospective learning environment, rather than after the fact, see you didn't do as well as somebody else, I think that would help. But I would be eager to hear from Vasanthi, for example, who's right here, about what would be additional barriers that she would foresee that we could actually address by building a network for sharing that's a little bit more amicable.
We've got a queue developing behind that microphone. I think Ray's is first.
Yeah, I want to pick up also on Pat's point about infrastructure, because the tendency with CIHR grants has been very short-term grants which tend not to be renewable, and yet much of the advantage is by funding infrastructure and making it readily available. I'm struck by how quickly Manitoba can respond to questions and turn out results, as opposed to how slowly it happens in some other provinces and how it happens in others. Is there any thought of building a mechanism for having an infrastructure so that the data could be available, accessible quickly, and the costs of maintaining the repository be there? Because right now, you're a fool to put a student on any project involving using administrative data, because by the time they're approved, they will have graduated.
Well, I am so glad that you asked me that question. So first issue is about the short-term grants. So I've had the privilege of actually looking at the CIHR data for the last 11, 12 years. And in fact, the health services research community is outstanding in the sense that it only asks for 2 years of funding, on average, as compared to 4 years of funding if you're a biomedical scientist. So it's not, and maybe that we get reluctant to actually grant people longer durations, and we provide a feedback loop on that regard. But we distinguish ourselves in actually tending to ask for short duration grants and having trouble getting, and having to resubmit much more than other communities in order to get funding, and then as a result not being able to get as many papers out the door because we're so busy writing grants because we only ask for 2 years of funding. So I would agree with you that we do need to resolve that problem, but that is resolved by us behaving differently and not by anything CIHR is doing. From CIHR's perspective, you can ask for a 25-year grant if you want. There's no rule that says you can't have that. But, you know, I wouldn't ask for a 25-year grant.
Please.
I mean, we should start with incrementing certainly the 2 years that we're typically asked for. With respect to the infrastructure, I think that's exactly why ISIS in Manitoba can get up and running and turn around answers pretty quickly, because they already have a huge investment in this infrastructure. In Quebec, it would take me 2.5 years to do what you guys do in 2 weeks. So there is a huge difference across the country in terms of accessibility of data. The strategy for patient-oriented research, David and Pat both sat on a working group to try to help us figure out what we needed for the data platform. They were keen and very instrumental in actually figuring out what the requirements should be there. And in fact, it is indeed to support this being a ready infrastructure that could be used for all sorts of health services and population health research questions. I think it's the gift that we have in this country, and we should be using it. And I think there's a recognition at the highest level that we have this as an asset that we should be using each and every province in the way in which both ISIS and Manitoba have shown they can use it.
Robyn, you've opened the floodgate of questions, so we've got 3 more. I think we've got time. Michael first.
Thanks. My name is Michael Hilmer. I'm from the Ministry of Health, and it was a great presentation, Robyn. I'm really interested in the user-generated cohorts that they use at Partners Health, and just wondering, both from your perspective as a grantor and then also ISIS's perspective as a data holder, that is this not a really promising way to get data into the hands of people who use it in a different paradigm than a traditional grant? Because obviously big gains are to be had by organizing data more efficiently. But a lot of this organization will probably take place outside of the realm of a traditional grant, and can you get it into the hands of users, hospitals first, probably because they have robust structures to begin with, and start microengineering changes. And what can ISIS and CHR do to support that? It's in a slightly different paradigm than big studies of the past.
Yeah, I've been really fascinated by the approach that that Partners has taken to actually building an interface that will allow their researchers to just go online and actually go look at the data themselves. I think both ISIS and Manitoba are poised, and perhaps BC Pop Health are poised to move to that as the next level, privacy concerns being considered. And that, I think, will do what has already happened already here. I've just been amazed at how ISIS Ontario, with these various satellite sites, has really pumped up the game in terms of what the production of science and scientific knowledge. If you move it up yet another notch to say, and we'll provide you with that kind of an access for you to be able to do that online, I can't begin to imagine what you're going to do is you're going to attract just a whole new cadre of scientists, because you'll be able to turn around things very quickly. The concern that people have always raised with that is, yeah, but they'll do a stupid thing and they'll get the wrong answer and they'll publish something that's wrong. And I think that we do have enough levers and controls in the system that no one's going to run off and publish things that are completely harebrained. I mean, we've seen some harebrained things happen, like, vaccines and autism. But I mean, we publish wrong things all the time, and eventually we sort it out. But, I don't see that as a huge barrier. So I would think that, the leadership would come from provinces that have already, you're close to getting there, you're almost there, you could just take it to the next level.
It's, if I can interject, the achieving a balance between being a data provider and maintaining a research institute with the scientific investment and the intellectual property you need to analyze these data sets well, I think is quite a challenge. And these data are not easy to analyze correctly, as you know, but at the same time we have to be open to new proposals like this. But it is a balancing act, I think.
Can I just pick up on can I make another little additional comment? One thing that I think would be interesting, and this is the VA approach, is to say, there's going to be interest in like tracking diabetics and looking at people with heart failure, looking at people with multimorbidity. And why don't we start by assembling a cohort of use all of the intellectual know-how here to create cohorts that will allow people to do things where you don't have to get so deep in the data and understand its dirtiness and complications and so on, is that you create cohorts, but you're doing it electronically and you're doing it on the fly. And that way you open up the world of possibilities to people who will be able to produce the manpower behind the wheel and very creative and thoughtful ideas about the kind of things that you can look at, and do so without compromising, essentially, or misunderstanding the data underneath it because you've already pre-assembled variables that make sense.
I would remind you this is becoming a little bit like a scientific meeting. This is our 20th birthday, remember? So David, Sue, and then Jack, and I think we might stop after that. So if I can inhibit anything else, please approach Robyn afterwards.
Robyn, my name is David Alter. Very much enjoyed the presentation. I guess the question I have is whether what your thoughts are on our approach, conceptual approach to accountability frameworks. If we're looking at health service utilization and comparisons, interjurisdictional comparisons, or if we're looking at the use of data to help shape policy, are we keeping in concert? Are we on the dialogue, involved in the dialogue, and if not, how, in terms of that whole notion of accountability, particularly for chronic disease, particularly as we move beyond hospitalizations into ambulatory care? You've spoken about patient empowerment. Rick talked to us about the life calculator, which is all sort of patient-driven, sort of behavioral factors. Whoops, there we go. And so I'm just very curious, like, are we still, too focused heavily on the provider level, the hospital level? How are we gaining insight into developing an accountability framework for patients in terms of their shared responsibility? And how much is that going to be part of our future in health service research versus somebody else's?
Gee, those are great observations and questions, actually. I think the one piece that that is missing is, patient-reported outcomes in the scope of things that you have in front of you, and that would definitely, that plus social and clinical data will certainly enrich things. If you look at, the big C transformation there, big T transformation that needs to occur to develop new models for chronic disease management, getting patient input early, fast, and in a systematic way, I think is going to be absolutely essential to get it right. I mean, there's not, we've got books and books and books about what we should be doing, right? And the hard truth of the matter is you're just going to have to get down there at the front line, get some clinical champions and leaders, get some end users, and try to figure it out. And so I would definitely, if I had to pick of all the three things I wanted to get there, I pick richer clinical data, and I get patient-reported outcomes. So that's already starting with some of the people who are building what I'd say live longitudinal registries the hard way. They're going and getting patient-reported outcomes. They're doing it in very creative ways, through cell phones, through this, through that, So there are neat things going forward. You wouldn't want to do it holus bolus at the beginning of in an organization, but you sure want to do it in a couple of important areas where, the data is not going to tell you a whole lot. Chronic pain, not going to tell you a whole lot. Ditto for mental health and a few other areas. So I pick your stripes as to which ones you'd want to do, but I'd certainly go after them, at least on a pilot prototype kind of basis, and see what you could do.
Jack, last question, very appropriately.
I would just like to point out a gray cloud that's getting increasingly darker on the horizon. Ontario, more so than perhaps the rest of Canada, pays about 30% of healthcare costs. The people pay out of pocket. It can be health insurance, it can be work-related payments, it can be various other sources. We don't have data for private payments. And as we approach the crisis of the funding of health care, the Ontario government's approach to this point has been delisting. And I think we're going to see more delisting, and we're going to see more private payments. And ISIS, Manitoba, British Columbia, other places, are going to have some wake-up realities to what are the implications for data.
Boy, this is a great last question, Jack. I'm so glad you asked it. It's been a bit of a worrisome thing. And I think I would love to hear, we won't have time, but I want to hear after, whether we should place some priorities in going after the private insurers to provide us with their data. The very interesting and thing I terribly worry about is that they grow, and I'm from a country, no, sorry, province.
Oh, that was a very timely slip. Oh, you're not going to get away with that one, Robyn. I'm sorry. With your new government.
Oh dear, let me put my other foot in my mouth.
Wow.
With a very big privatization agenda, you know, we have a lot of private diagnostic clinics, and what happens when people get into trouble anecdotally is they get thrown into the public net.
Yeah.
And so there's a growing, and I think personalized medicine will be going down that pathway. And so this is a bit of an issue because it's the hidden part of the healthcare system. And interestingly enough, recently Quebec decided they were going to actually fund reproductive technologies precisely because they wanted to be able to control what was happening. Because the cost of these preemies in the triplet burst, quadruplet burst, quintuplet burst in the NICUs was huge, and it's like not just in the NICU, it's long-term effects for them. And so I think I guess of all the priorities we have, how hard should we push to go after the private insurers? I think they may be willing to come to the table and work with us to try to get the private insurance data. We could certainly lead that at the national level. It's just a matter of all the things on our list, where does that sit? Is it in the top 3? If it is, then we'll put the human effort and resources behind it to do it.
I had to say, but the alternative is provide universal coverage for everybody in all drugs. Just thought I'd drop that one in. Just to get the data, of course. Vasati might comment on that. Who knows? She's going to come up in a minute. Robyn, thank you very much. I mean, the number of the response, the fact that everybody's still in the room, the number of questions, is just testimony to the interest of the talk. So that was a wonderful review. Thank you very much.